I'm Michael Betel, President and founder of the Fatty Liver Alliance. We raise awareness about the risk, causes, and complications of fatty liver disease and help those already diagnosed with MASLD and MASH by advocating for access to approved treatments and care. Today, I am very excited to introduce my good friend, Dr. Naim Alkhouri, who's a transplant hepatologist and the Chief Medical Officer and the Director of the Fatty Liver Program at Arizona Liver Health in Phoenix, Arizona. Dr. Alkhouri, you and your colleagues just had a paper published in JAMA Network with some very concerning numbers regarding MASLD growth from 2020 to 2050. What are you predicting over the next 30 years, and how worried should we be?
Thank you, Michael, for having me. It's always a pleasure to be with you and the Fatty Liver Alliance. Really, you guys do an amazing job raising awareness. I'm glad you're highlighting our paper today because it's really raising some concerns about increase in prevalence of MASLD, fatty liver disease, and more importantly, the aggressive forms like MASH and MASH with fibrosis. So this was a collaborative effort with the Cleveland Clinic. We actually built this mathematical model that can, do projections for us to estimate the burden of the disease in 2050. And what we showed is that, in 2020, the prevalence was around 33%, and by 2050, we project it's going to be around 41% in terms of, steatotic liver disease with metabolic dysfunction, MASLD, or what we used to call fatty liver disease. More importantly, we showed that there will be an increase in MASH, the aggressive form of fatty liver disease, from around 5.8% to close to 8% of the general adult population. And even more concerning to me is the prevalence of MASH with significant fibrosis, so stage 2 or higher. These are the patients that will need pharmacologic treatment with medications such as resmetirom, for example. And we showed that there will be a doubling of this population from around 6 to 12 million people in the United States. Of course, Michael, as you know, MASLD is a risk factor for cirrhosis and its complications, including hepatocellular carcinoma, liver cancer, and some patients will actually need liver transplantation. So today we estimate that steatotic liver disease, MASLD is responsible for about 11,000 cases of HCC in the United States, and we project that in 2050 it will be around 22,000, so double the number. And we estimate also that around 2,000 liver transplants are being done annually in the United States because of the indication being MASLD. And we estimate this number will actually triple to 6,000 liver transplants done every year in the United States because of MASLD and MASH. Of course, we try to account for the approval of resmetirom, which is the first FDA-approved medicine. We anticipate that other medications will be approved. Potentially, semaglutide could be approved this year, which will be another great addition for our patients. And we hope that by the end of this decade, we will have 4 or 5 MASH drugs. So it's really hard to predict the impact of these medications. But again, at the end of the day, if the trends continue, we are going to be in big trouble by 2050.
Yeah, and the numbers are very scary. And after I read the paper, I started talking to other people about it, of course, because it's very important. One of those people was Jeff Lazarus, who asked exactly what you just mentioned, and he was saying, "Well, do the numbers take into account all the upcoming treatments?" And there are so many. I guess it's like you said, it's very hard to predict the impact of those drugs. But when you were doing the estimates and you were saying that you're going to get like tripling of transplants as an example, is that taking into account the treatment or that's without, is that modeling like based on current growth rates, right?
It's taking into account some of the treatments that are available today, but we, couldn't really adjust the model based on the approval of other medicines that are in phase 3 trials now, because we didn't want to use data from phase 2 trials. Sometimes, the percentages, the response rate change between a small phase 2 trial as we go into large phase 3 trials. So, we looked at resmetirom, we looked at the effect of GLP-1s, but not, hypothetical approvals of medications that are still in phase 2 trials.
Okay, so here's my big question of the day. We talk about individual approaches where we tell people, do more exercise and improve your lifestyle management. But what are we going to do to impact this on a more global level? Because this is a bigger issue. So, what if you had to pick two or three really impactful, even if they're longer term approaches, what should we do? Where should we start, and what do we want to get to?
We should start early because we see more MASLD now in children and adolescents. And the longer you have the disease, the more likely you will progress to significant fibrosis and eventually cirrhosis. So I think starting early and really utilizing the non-invasive test that we have validated and we've been using in the adult population more frequently in the pediatric population, and making sure that we have good studies that show us if the thresholds are the same in children or they might vary actually. So we definitely need more studies in that population. Obviously, this is a global problem, as you said, and it has to do with our diet and food and lifestyle. And we would need to target upstream. The idea is that, prevention is always key, and it's much better to prevent people from ever progressing to significant fibrosis than to treat with pharmacologic treatment after it's kind of, too late and now you're trying to salvage. However, this is, a bigger issue that will require policy changes and working with NGOs and governments. And I think, as a clinician, I think, again, to continue to develop new drugs that will help our patients that we see in clinic and, expanding the pipeline and looking at combination therapy may also help us, to make a dent in this global epidemic. One thing I would like to say is that, we spent a lot of effort to develop this mathematical model, and maybe the audience would be interested how we make these projections. But the way we do it, we have data on the prevalence of MASLD and MASH, fibrosis, HCC from 2000 to 2020. So we know the numbers. We actually had to go through the entire medical literature on all the studies that looked at the natural history of the disease, how you progress from one fibrosis stage to the next, what percentages are there, and build the model. And then we use the existing data from the enhanced database to estimate the prevalence between 2000 and 2020. We also looked at the numbers for liver cancer from the National Cancer Database. We call it the SEER database. We looked at the numbers for transplants from another database called the UNOS database. So we built the model, we applied it to the population in 2020, and we made predictions for from 2000, and we made predictions for 2020. And we showed that by using the model in 2000, the predictions in 2020 were accurate and replicated the numbers that we knew actually existed in 2020. Does that make sense?
Yeah, oh, for sure. And so I have to ask this question, then follow up to that is how many people and how many hours does something like this take to put together?
I mean, this was a big team at the Cleveland Clinic, and this is a long-term project that takes a month. It's not just a weekend to build this because, as I said, you have to review the entire existing medical literature. You have to spend hours and hours building the model. Then you have to calibrate based on existing data, make sure your model is not making crazy predictions. But what I like about this, Michael, is that now we have the model. We know it works. We know it's accurate. We made the predictions for 2050. So now we have a benchmark. Okay. So if these numbers actually materialize, I think I'm going to feel very bad. I think we're all going to feel collectively as we failed our patients. So my goal and my hope is that, none of these numbers will become the reality, and that, by working together, we can actually change these predictions. But again, based on the trends we have today, this is what we're looking at.
When would the next one do? Like, would you do it every 5 years, do you think?
Yeah, I mean, you can, continue to refine the model and look at existing data. But in terms of, the predictions, I mean, you can. calibrate based on new realities. So if we have, three new medications, we can potentially, model the impact of newcomers into the market on the disease outcomes.
Okay, so this is your baseline case, right? So hopefully the worst scenario that
Yes.
it doesn't get worse. If we don't make an impact on things like ultra processed foods, it's gonna be hard. Um, yeah, no, thank you so much. As always, every time we connect, you have new information to share, and so I know that people will definitely want to hear this from you, and we'll do our best to spread the word. Let's
Thank you so much, Michael, for highlighting this. I also want to, leave with this message for all researchers in the space. If you guys are interested in utilizing the model, if you have, a new intervention, if you want to look at a special patient population, reach out to me or Michael. We are happy to connect you with the team at the Cleveland Clinic and potentially collaborate on future projects.
Dr. Alkhouri, thank you so much as always. We'll do this again
Thank you,
soon.
my friend.
Thanks.